In the past 2 weeks, he had acute deterioration in his behavior in memory. He needed help for almost everything, so he had restricted his physical activities, and he also had developed urinary incontinence. So when he presented to us, when we saw him, he was alert, he was obeying commands, bright, but completely disoriented. He didn't know where he was, and he didn't know why he had come to the hospital. So no focal motor weakness. Hemodynamically, he was stable. Blood workup was unremarkable. His baseline cardiac function was good, and effort tolerance was good till 2 weeks back. As I said, he used to walk twice daily, did all his activities without assistance. Imaging revealed bilateral subdural hematoma. Because of its bilateral nature, there is no midline shift, but there is definitely uh, mass effect and needs evacuation. So the plan was to place bilateral burr holes and evacuate chronic subdurals. And then a couple of days later, as per our institutional practice, we subject them to middle meningeal artery embolization to prevent recurrence in the future. In our practice, we do both these under general anesthesia. There is no practice of local and sedation. So when such patients present to us, our perioperative concerns include elderly patients with compromised organ function. Though their baseline functions look okay, we don't know how they will vary under anesthesia and surgical stress. Risk of perioperative cardiac and renal dysfunctions. Multiple anesthesia exposures. There is one surgery. If there is recurrence, probably a second surgery, and then is going to the cath lab for embolization of arteries as well. So minimum two, maybe more anesthesia exposures. And apart from all that, one more concern is postoperative cognitive dysfunction. We'll come back to the case later. Now, cognitive dysfunction after surgery has been described since very, very early. This is a paper from 1887 produced by the British Medical Association. The topic is insanity following the use of anesthetics in operations. So
నేనైతే ఏమైనా చెప్పండి.
even in the 1880s, people recognized that after exposure to anesthesia, there was some behavioral abnormalities when they woke up from surgery and anesthesia. They did not know why it happened. It was too early to understand all that, but that was being picked up, so it was a significant issue by then. So almost 100 years later, in Lancet in 1998, a first major study regarding post-op cognitive dysfunction came up. It was called the ISPOCD-1 study. The authors looked at cognitive outcomes in more than 1,000 patients aged at least 60 years. So their finding was that 25%, nearly 26% of patients had post-op cognitive dysfunction at 1 week, and nearly 10% of those had persistent dysfunction at 3 months after surgery. So, and in their analysis, they found increasing age and duration of anesthesia, low level of education, repeat surgeries, post-op infections, and respiratory complications as risk factors for POCD. Now, those studies which were included in the ISPOCD-1 studies, they were analyzed further, and the results were pooled as ISPOCD-2 studies. And the final list of risk factors were advanced age, frailty, multiple comorbidities, presence of pre-existing neurocognitive impairment, like in our patient who already has Alzheimer's since 2 years, mobility and malnutrition issues, and prolonged or multiple surgeries. Now, out of all these, the first six, we have no control when they come to us. We cannot do anything to change this. What the last one, too deep anesthesia, which they have identified as a risk factor, is completely under our control. That is something we can manage, we can do, so that our patients are little better in the post-op period. Now it is being increasingly recognized. This is an editorial kind of thing from ASA about a couple of months back, where they're trying to say that a major breakthrough is on the way. So even if you see their image, they've proposed three pathways of POCD. First is pre-existing and neurologic dysfunction. Then there's surgical inflammation because of interruption of blood-brain barriers and activation of inflammation. Now these, as I said, you have no control. But what we can control is perioperative neurological alterations by monitoring the perioperative EEG or other indices of brain function. Now, this is just an illustrative paper. I picked it up for showing here. There are multiple papers which will show that depth of oral processed EEG guided anesthesia will decrease post-op cognitive decline and delirium. Now, in this paper, which came up around 10 years back, They studied 900 patients. They were randomized uh, to either receive anesthesia based on BIS or routine practice. Even in the routine care group, they had monitored BIS, but their interventions were not based on BIS readings. Here, all the interventions were based on the BIS reading. So they found that when BIS was used, if they were practicing TIVA, the effect side propofol concentration required was lower, and if they were doing volatiles, the MAC required was only around zero point 0.6 or so. While in the routine care group, the MAC was around 1, and the effect site concentration requires around 3.3. So 50% higher requirement in routine care group. Now, those patients who were managed by BIS, the average BIS for those patients was 53 during the case. The range was from 48 to 57, while in the routine care group, the average BIS was 38.6, and most of them spent their BIS between 31 to 49. So you can see that the highest BIS, average BIS in the routine care group was almost same as the lowest average BIS in the BIS group. And the time duration for which the BIS was too low, which is less than 40, was around 7 minutes in the BIS group and around 25 minutes in the routine care group. So significantly longer time was spent in a deep hypnotic state. So when they analyzed the cognitive outcomes in these patients, they found that 15% in the BIS group and 25% in the routine care group. So almost 50% more people in the routine care group had immediate post-op delirium. And after 3 months of surgery also, 10% in the BIS group and 15% in the routine care group. So significantly higher number of people in the routine care group had a post-op cognitive dysfunction. And they found a number needed to treat of 23. So if BIS directed management was done in uh, 23 patients, we could avoid post-op cognitive dysfunction in one patient, which is a reasonably good number. So with this background, we'll come to the topic. What is depth of anesthesia? It is the degree to which the CNS is depressed by a general anesthetic agent. The depth depends on the potency of the agent and the concentration in which it is administered. Now, why we use the word depth and not strength or any other word is because of the feeling that for more and more action to occur, the anesthetic agent has to delve deeper and deeper into the CNS. For hypnosis, which is a cortical function, if the agent is present in the cortex, it is enough. We need a lower concentration. For immobility, which is a spinal action, the anesthetic agent has to penetrate into the spine. That is why it has to go deeper, and we have to reach 1 mic. And to prevent sympathetic response, which is even more deeper, it has to go into the spine and come out into the sympathetic system. We need still higher concentration. That is why probably we use the word depth of anesthesia. Now, this is a picture of a monitor of a patient under general anesthesia. As per standard ASA recommendations, there is heart rate with ECG, there is pulse oximeter with saturation, there is invasive BP, and there is temperature. Almost all of us would agree that this is a good enough monitor for any patient undergoing general anesthesia for a surgery. But which of these parameters is looking at the effect of the anesthetic on the brain? None of them. So the main function of anesthetic drugs is sedation and hypnosis. What we look at are the cardiopulmonary effects, which are basically side effects. We titrate our anesthesia based on the side effects and not the effects, which are not the direct indicators of the drug we desire. So even in absence of clinical changes in heart rate or blood pressure, there can be intraoperative neurological events which go unpicked up. Hence, we need a more direct and reliable method of measuring drug effects in our practice. Like how we look at the ECG to get an idea of the cardiac activity, there is a counterpart in the brain. It is the electroencephalography or the EEG. But unlike the cardiac cells, the neurons fire independently and asynchronously. So there is no reproducible EEG waveform. It is just a collection of random waves with the frequency varying from zero point 0.1 to 500 hertz. Just for our understanding, so that for better replication, we divide them into different wave names based on the frequencies. The high frequency waves are called gamma waves. The frequency is 30 to 80 hertz. Then the beta waves, where the frequency is 14 to 30 hertz. The alpha waves at 8 to 13. theta is 4 to 8, and the slowest are the delta waves where the frequency is less than 4 hertz. Correct interpretation of the EEG is essential for decision making. We can look at the frequency and amplitude and guess the activity of the brain. But however, like I said, it is not like the heart where all the fire neurons are working together and producing one wave. Whenever we look at the EEG, there is no single dominant frequency. There are multiple waves, different frequencies at different points. So it becomes very difficult to interpret, and it takes learning and experience. So just for example, this is a 1 second strip of a raw EEG waveform under anesthesia. Now looking at this, can we guess which wave this is? Now if we count, now this is 1 second. So if we count, there is one, two, three, four, five, six, seven, 8 waves. So I think everyone would agree that this is an alpha wave with a frequency of 8 hertz. But actually, it is not. If we look more carefully, there is one, two, three, and 4 waves. So there is one wave with a frequency of 4 hertz, and on top of that, there is one more wave with a frequency of 8 hertz superimposed. So this is basically 2 waves mixed together forming one wave. Now this is just 1 second of an illustration. In actual life, there are multiple waves, each with its own frequency, all varying in their own phases. Superimposed, we do not get a normal, understandable wave. Actually, many anesthetic drugs produce characteristic effects on the EEG. But in general, as patient goes under anesthesia, the EEG changes from high frequency, low amplitude to low frequency, high amplitude. Once this was realized, multiple efforts were put in to monitor EEG under anesthesia. But because of the bulky equipment and processing required, it was not successful. But with now the development of faster microcomputers and chips, this is being overcome. This is just a basic representation of various EEG patterns. When we are awake, it is fast and small waves. As the patient goes deeper and deeper, the waves become slower and slower, so the frequency reduces, and they also become bigger and bigger. The amplitude increases, and these are deeper states which we will discuss in the coming minutes. Just a representation of the history of EEG monitoring. Even in 1930s, people had noticed that with increasing doses of ether, EEG changes appear. Then they found it for nitrous oxide also. In 1971, in the 1970s, people started to process and to try it and make it more understandable. In 1990s, the BIS came up, and in 96, FDA approved the BIS monitor for clinical use. Now, BIS, we all know it comes as a standalone monitor also, and now with it becoming generic, it can also be incorporated in our multi-para monitors using a module. Now, this I feel is a more complete monitor anesthesia. Along with the hemodynamic parameters, we also have a EEG waveform and the BIS, which is looking at the effects of the anesthetic agent. BIS was the first FDA approved product available for routine intra-op use to monitor anesthetic depth. Produced by Aspect Medical Systems. It gets its name from bispectral analysis. Bispectral analysis is one of the parts of the algorithm which is used to interpret the EEG. So that is why it gets its name. And it is the most extensively used and studied monitor for depth of anesthesia. The problem is this algorithm is proprietary. The makers have still not made it available for complete understanding by the general public. What they have told is that it uses a statistical process to analyze the EEG, and then it comes up with a dimensionless a number on a linear scale. There is no unit. It is just a number based on statistical analysis. But with and as it was being used and people reported more and more experiences, the makers also have gone back, revised, made a number of changes over time, and to improve reliability. Currently, version 4.1, which was developed in 2004, is in commercial use. This is just to look at the development of the algorithm. The first algorithm came up in 1992. Like the practice was then, the endpoint for defining the depth was MAC or hemodynamics, and it was agent specific. For each agent, we had to, like how we do it for MAC, we had to enter the agent and know, and only then the BIS would be reliable. But soon they realized that this is not a proper endpoint to monitor anesthetic depth, and they changed over to hypnosis or recall. With subsequent modifications, all these changes were incorporated. They improved the artifact removal, they improved the EMG detection and elimination, made the waves smoother. So version 3 in 1995 was approved for monitoring anesthetic effect, and the current version, which came up in 2004, has been used to decrease awareness under general anesthesia. The first thing we need to know is how the sensors work. Now, these are the sensors available in the market. This is a standard sensor which most of us use, the BIS Quattro. This is a pediatric sensor which has smaller leads so that it can be applied over smaller foreheads. And this is the bilateral BIS has now come up. It is there for a couple of years now in the market. This can be simultaneously used on both the sides to monitor each hemisphere independently. So they are self-prepping electrodes. They are like ECG. The only thing is they are connected to each other so that it is easier to apply on the forehead. They use a small plastic sponge with a conductive gel embedded to establish good skin contact. The standard electrode consists of four. Rarely there may be three electrodes. The circuit is also incorporated inside. If you just turn it over, you can see so that it is easier to connect and use. The four electrodes, out of these four, electrode 3 is the active electrode, which is it is supposed to be applied on the thinnest part of the skull, which is the temporal fossa, so that it is closest to the brain. That is the one which is actively picking up the EEG activity. Lead 1 is the frontal electrode, which is applied in the midline. That serves as a reference for 3. So whatever activity is happening at 3 with reference to 1 is what is finally displayed and analyzed. 4 is to pick up EMG artifacts, so it is put above the eye. It looks at the yeah, EMG activity from the eyeball as well as the frontalis muscle. And 2 is the ground electrode, which will eliminate ambient theater electrical interference. Now, as I said, the algorithm for BIS is empirical. It is not based upon any law or equation. But what we know is that there are four subparameters which are extracted out of the EEG analysis and are used for calculation. I'll talk about each of these in detail. Now, whenever we analyze a waveform, we can analyze it in two ways. One is time domain analysis, where we analyze how the wave is changing over time periods. The other is the frequency domain analysis, where we can study what is the frequency of the wave, and if possible, we break it down into its constituent waves and then study the frequency of each of the wave. So when we do time domain analysis, we get two parameters called the burst suppression ratio and the quasi suppression ratio. And when we do frequency domain analysis, when we study the frequencies of the constituent waves, we get the other two parameters, the relative beta ratio and the sync fast slow. Now, this is the algorithm which the makers have put out in the market. They just say that this is how the BIS is calculated. So what happens is once the EEG is picked up by the monitor, the analog signal is digitalized and all the artifacts are filtered out. The artifacts can be from the ECG, from the EMG from eyeball movement or the frontalis activity. The EOG, the electrooculogram also interferes with the BIS. Because EEG by itself is a small wave, any electrical activity around it can interfere with EEG. The implanted medical devices like pacemakers, cautery in the theater, any electrical activity in the theater can all uh, interfere with BIS, so they are all filtered out. Next is first part of the analysis, which is the uh, detection of suppression, and then we get the two parameters. The first is burst suppression. When we say suppression and in an EEG, it is a period of isoelectric activity. That means the amplitude of the wave during that time is less than 5 microvolts. So for burst suppression ratio, what the monitor does is it analyzes a 60-second EEG segment and sees for how long the EEG was isoelectric. So for how long it was less than 5 microvolts, then that part is called the suppression, and the remaining activity is called the burst. So in this case, if the monitor is saying suppression ratio is 38, that means in this segment, for 40% of the time, the EEG was isoelectric, and for the remaining 60%, there was electrical activity. Now, the problem with this is there needs to be a stable baseline so that the uh, algorithm can pick up the activity as flat. So they introduced the quasi-suppression index where even if the baseline was flat or even if there was some movement, the algorithm can still pick up that activity as isoelectric. So this involves analysis of only slow waves and then to detect periods of suppression. So together, these two, because they need a very low activity or isoelectricity, these two are very important in analyzing the time in which the patient spends in very deep lanes of anesthesia. The second part of analysis is the fast Fourier transform and the beta ratio. Now, what is fast Fourier transform? It is basically what happens to white light when it passes through a prism. Like when it passes through a prism, it is broken down into its constituent waves. When an EEG waveform is subjected to fast Fourier transformation, all the constituent waves can be separated. Now, this part in this picture has been subjected to fast Fourier, and they have found delta wave, theta wave, alpha wave, and beta waves. Now, these are from this part of the EEG. When the entire cerebral hemisphere is looked at and all the waves are looked at, we will find multiple delta, multiple theta, alpha, and multiple beta waves. So you plot each of them on the graph, then you will get a line graph which will tell us what is the number of waves of each frequency in that part. So that will be the power, and this graph is called the fast Fourier graph. So once we fast Fourier transformation is done, we know what is the number of beta waves, what is the number of alpha, delta waves and all. So we can calculate the relative beta ratio. It is the ratio of the number of waves in beta 2 range, that is 30 to 47 hertz, to the number of waves in alpha and beta 1 range, that is 11 to 20 hertz. This is the relative beta ratio. Now, because we need waves in the alpha and beta range, that means the patient is not very deeply sedated. He is mild. There is some alpha and beta activity also. So it is an important parameter in cases of mild sedation. And the third part is bispectral analysis and sync fast flow. Now, bispectral analysis is very difficult for someone like me to understand. So what it basically does is it is a measure of degree of synchrony among the waveforms. Now, as I said, the EEG is pretty random. Every neuron is firing in its own way. So it measures how synchronous the waveform is. The general belief is that with increasing depth of anesthesia, the synchrony improves because more and more neurons start becoming silent. The remaining ones are working in a synchronous way. So this will tell us how synchronized the EEG is. So basically it looks at the synchrony between slow and fast waves. Now because this parameter needs both slow and fast waves, it is slightly deeper. It is not very deep like suppression. It is not very light like RBR. It is in between. So probably at the surgical anesthetic planes, this parameter is important. Just to summarize, burst suppression and quasi-suppression, they are both the time analysis and look at the fully suppressed or nearly suppressed EEG. Relative beta ratio is a frequency analysis, looks at high frequency activation, and sync fast flow is a frequency analysis which looks at low frequency synchronization. Now, after we understand all this, we will look at what all display the monitor gives. First, when we apply the electrodes and look at the monitor, the first thing we need to see is look at the signal quality index. Now, this index represents the quality of contact between the skin. It doesn't tell us whether the waveform is from the EEG or from anything else. It only tells us that there is good contact between the sensor and the skin. Even if you put the electrode on the chest, the signal quality will be high because it doesn't analyze what waveform it is. It just tells us that the contact is good. Uh, Once it is applied on the forehead, it will tell us the quality of EG signal. If the SQI is 100, that means the quality of signal is very good. And if the SQI is 0, it is of very poor quality. The BIS value is displayed only once the SQI crosses 15, but the BIS value is actually reliable only if the SQI is more than 50%. Next, we look at the electromyography or the EMG. It represents the total power of all the waveforms in the frequency of 70 to 110 Hertz. The algorithm by default picks up all the electrical activity in the range of 70 to 110 hertz as EMG. So it analyzes those waves and the total power is displayed as EMG on the uh, monitor. It is mathematically transformed and expressed in decibel units. For BIS to be reliable, EMG should ideally be below 30 decibels so that we know that there is not much of EMG interference and that the BIS is most of it is from the EEG only. Next, which the newer monitor is displaying is the mean frequency. Here you can see the display being shown. It is the mean of all the frequencies that are being picked up. So half of the frequencies, half of the waves have a frequency above this value and half of the waves have a frequency below this value. Rather than the number, if we look at the trend, we can know that if the MF is increasing, that means the patient is moving to faster frequency waves, he's becoming lighter. Or if the MF is decreasing, that means the patient is going deeper into deeper planes. Next is spectral edge frequency. By default, SCF is for 95%. That means that it is the power of or it is the frequency below which 95% of the waves have their frequency. We can also have an SCF for 50%, but that is of less significance. SCF 95 is the most significant value. So in this example, the SEF is 14.2. That means 95% of the waves that are being analyzed at that time have a frequency less than 14. So 95% of the waves are in the alpha, theta, and delta range, and only 5% are in the beta range, which is what we target under general anesthesia. So generally, even if you don't have this number, if you have a monitor which has just EEG and which can give SEF, roughly BIS is equal to SEF into 2 plus 16. So in this case, we would get a value of 44, which is pretty close to the actual BIS. For total power, another value which is like mean frequency, it is a sum of the power of all the frequencies. So like mean frequency, if it is increasing, that means the patient is moving towards lighter planes. And if it is decreasing, that means high frequency waves are shutting down. The patient is going deeper. So the problem with BIS, as I already said, was that they did not reveal the algorithm. They just said this is the monitor. We have our own algorithm, which we will not reveal. But then you use this for titrating your anesthesia. People will not take it. People will try to analyze. Not everybody will just blindly trust something which they cannot understand. So there are many papers. People try to analyze it in various forms. They just try to do work out how this is working. So this is one interesting paper which I found. So what these authors did, they sat with a few statisticians and uh, who can analyze the waveforms, and they propose that how BIS works is it first looks at the burst suppression ratio. If the burst suppression is more than 50%, the BIS is less than 20. So there is no further analysis needed. You just know that the BIS is less than 20. If the burst suppression is less than 50%, then you need to look at the spectral edge frequency. With burst suppression of less than 50%, is the SEF is less than 15 hertz. That means most of the waves are alpha or below. The BIS is between 20 to 40. If the SEF is between 15 to 20 hertz, the BIS is between 40 to 60. And if the SEF is more than 20 hertz, that means most of the waves are fast beta waves. Because you have a lot of beta waves, you analyze them further. You look at the relative beta ratio. Now, if relative beta ratio, if it is less than minus 0.7, that means there are slower beta waves than fast. That means patient is still slightly sedated. So BIS is 60 to 80. And if it is more than minus 0.7, that which means that most of the beta waves are also fast beta waves, not much of slower ones. That means probably the patient is fully awake. BIS is more than 80. Now, this is a very promising calculation. It is easy for us also to understand. And the authors actually report that without looking at the BIS, if you have these values, you can predict the BIS with a positive predictive value of around 80 to 90%, which is very, very promising. So with this background, we know we will come to what targets we need to achieve. A BIS, as I said, is on a linear scale, no units. If the BIS is 100, patient is fully awake and responds to normal voice. Between 60 to 80, patient is sleeping, but he can respond to loud commands or mild shaking. So that is the probably the plane of light sedation, conscious sedation which we want. So that is a target for conscious sedation. This 40 to 60, there is no recall. He is unresponsive to verbal stimulus. That is the depth we need for general anesthesia. 20 to 40 is less than that. That is too deep. And below that, as it approaches zero, there is a lot of burst suppression. That is territory we don't want to venture into. So again, coming back to that, even if you don't have this, if there is a monitor which can also give you EEG and SEF, just look at targeting no burst suppression and an SEF between 15 to 20 hertz. That is where your patient should be safe. So if you're using BIS, this is a general guide as to how BIS directed management can be useful. So whenever the BIS is 60, that means the patient is light. If there is increased sympathetic response also, increase the depth of anesthesia. If even at this point the patient has stable vitals, rule out artifacts, make sure there are no interferences, probably EMG or cautery or something which has falsely elevated the BIS. If that is not there, then you still need, even though vitals are stable, you still need to increase the depth of anesthesia. If there is increased BIS and simultaneously decreased vitals, or if there is bradycardia and hypotension, there is probably some surgical insult that has happened, probably a vasovagal, or probably there is some blood loss. So give IV fluids, give vasopressors, or if there is an epidural in place, or if there is a Dexmed infusion going on in the background, that has resulted in decreased vitals. So decrease that, and once the patient has stabilized sympathetic wise, increase the depth of anesthesia because BIS is still low. BIS 40 to 60 is what we want. When in spite of that, if there is increased sympathetic response, it is probably pain. So increase your analgesic dose, or otherwise consider sympathodialytics. If the patient is stable with this BIS, that is the area you want to be. Continue the same regimen. But if there is a decreased sympathetic response in at a BIS of 40 to 60, then again, as I said, there is some surgical insult, or the analgesic component is too much. So decrease the analgesic, support with IV fluids and vasopressors. If BIS is less than 40, the patient is very deep, the hypnosis part is very deep, but still there is increased sympathetic response. So you decrease the hypnotic component, simultaneously increase the analgesic component. There is pain in spite of the patient being deep. So decrease the hypnotic component, increase the analgesic component, and after that consider sympatholytics. If the patient is stable, but the BIS is less than 40, he is still deep, need to decrease the hypnotic component. If the BIS is also less and the vitals, I mean the hemodynamic parameters are also decreased, first, rule out cerebral hypoperfusion. There is hypotension, there is bradycardia, and the BIS has fallen. That means the EEG activity has fallen low because of inadequate oxygen supply to the brain. So rule out hypoperfusion. If you are sure that that hasn't happened, and decrease the hypnotic and analgesic components and support the hemodynamics with IV fluids and vasopressors. So this is a rough guide as to how to use or how to titrate your anesthesia based on BIS. In spite of all this, BIS, like any other monitor, has its own limitations. First is the electrical interference. There is significant EMG activity when the patient is sedated but is spontaneously breathing. So his eyes are still moving, his forehead is still moving. That will cause a lot of interference. The BIS will be falsely high. Because most of the waves in 70 to 110 hertz are taken as EMG, the BIS will not take the EMG activity uh, in the lesser range. So even if uh, there are waves below the, even if the EEG waves are there, which are higher in the higher range, the BIS may not take them as EEG waves and falsely give BIS values. Implanted medical devices like pacemakers can also cause artifacts because of their own electrical activity. Anesthetic agents also have, BIS also has limitations based on anesthetic agents. It is general experience that a patient anesthetized with a single anesthetic drug to achieve a particular BIS is more sedated at the end of procedure than a combination of drugs. Even though the BIS is same in both these patients, because there is a combination of drugs, we have given a little less amount of both those drugs to achieve the BIS, so they are probably more awake at the end, as in comparison to a single drug. So the BIS number by itself will not tell us the quality of awakening. The other drawback is that this algorithm, when it was developed and validated, they only took drugs which act on the GABA receptors like benzodiazepines and barbiturates, propofol, and volatiles. They did not take other drugs which act on the other receptors like ketamine or dexmedetomidine or even etomidate, which acts on the different subreceptor. So these drugs, when we are using, this becomes unreliable. It is only reliable when GABA receptors are in play, probably because of different mechanism. Now, ketamine and nitrous, they basically have an excitatory effect on EEG. So because the EEG activation is there, because frequency increases, this actually increases even though the patient is going deeper with these drugs. Uh, we have also seen that low dose of benzodiazepines or propofol, it is known to cause inhibition of the inhibitory neurons. That means there is paradoxical activation of the EEG at very low doses. So even though patient is mildly sedated, there is an increase in the BIS. That is another fallacy. The opioids, by their inherent lack of effect on EEG, do not have any effect on BIS. So even though the patient is sedated with a high dose of opioid, the EEG is working well, so the BIS will be falsely high. The other problem is muscle relaxant. As I said, any frequency above 70 hertz is taken as EMG by the BIS algorithm. Now, but what happens? There is some EMG activity below 70 hertz also. Now, that is not taken as EMG, but as EEG by the algorithm. When muscle relaxants are given, the EMG in the below 70 hertz also diminishes. So the machine picks it up as fall in EEG and spuriously low BIS values are given on administration of relaxants, even if the patient is fully conscious. That is one care you should take when you are using relaxants and BIS. Next is age. Because of lack of brain maturation and inadequate synapse formation, the EEG patterns in infants less than 6 months is not the same as that in adults. So this is unreliable. And next is temperature. This is known to decrease by around 1 unit for each degree reduction in body temperature. This is probably because with the hypothermia, the CMRO2 decreases, the EEG activity decreases, the EEG is gradually slowed down, and with deep hypothermia, there is burst suppression pattern also. So when in such extremes of temperature, the BIS becomes unreliable. Next, in patients with neurological impairment, this is not a very reliable tool. If the patient is unconscious because of underlying cerebral pathologies like a tumor or a head injury patient, this is not a very good indicator of the level of consciousness. They are generally low in patients with neurological impairment. And there are certain patients who have a normal EEG activity, but just their EEG voltages are low, or previous insult to the frontal cortex may cause an abnormal EEG pattern, like a previous surgery or an infection has damaged the frontal cortex. So they have abnormal EEG patterns. So even if the patient is fully awake and alert, they have abnormally low BIS because of abnormal EEGs. The other limitation of BIS is that BIS looks only at the activity of the cortical part of the brain. It doesn't look at the subcortical structures such as the brainstem and spinal cord. So a patient who is deeply unconscious as a result of brainstem pathology like a brainstem stroke or a tumor which has infiltrated the brainstem, the patient is fully unconscious, but because the cortex is well and firing, the BIS can be spuriously high. You cannot use BIS as a depth of anesthesia marker in brainstem injury patients. And the other problem is because it doesn't look at the spinal component of the neurological activity, a BIS of 40 to 60 does not ensure that the patient will not move to painful stimulus because movement to pain is a spinally mediated action and BIS doesn't look at the spine at all. So even an adequately under patient as per BIS can still move if the painful stimulus is significant enough. And the algorithm itself has some limitations. BIS, although we say it is real time, it is not like ECG where beat to beat monitoring is done. It is an average of the EEG activity in the past 15 to 30 seconds. So there is a time lag of around 15 to 30 seconds. It is a representation of what has happened in the previous time group. So it is not actually real time. So in cases where you need real time EEG activity like induction and maintenance with a target control delivery system. You need to titrate your propofol targets based on BIS. There is a 30-second lag. So whatever effect concentration you had attained 30 seconds prior is what is being shown in the BIS now. So you cannot titrate your targets in and very short intervals. The other thing is that BIS is basically a mathematically and statistically processed algorithm of one part of the activity arising from a highly complex physiological organ. So this basic fact itself is a limitation. Although BIS is highly robust, highly reliable, although they have made it more reliable by going back and improving the function, it still cannot replace actual visual processing and analysis of EEG waveforms by an experienced observer. There is still, because of the limitations in the algorithm, looking at the EEG waveform and trying to judge what is happening. One, because it is real time, and two, because there is more data which we can get from looking at the EEG than looking at the number. That is the reality. Now, for example, this is a picture of a patient we got maybe around a month back. Uh, the heart rate is okay. The BP is slightly high, but we will forgive that. The other parameters look normal. The SEF is 16.9. The EMG is good, so the BIS value is I mean the BIS signal is reliable. So looking at this, what would you guess will be the BIS of the patient? The patient looks okay. There is hemodynamics okay apart from mild increase in pressure. So 17, like I said, into 2 plus 16. So 17 SEF, we would expect a BIS around 50. That is a perfect plane of anesthesia which we would expect. But this was what we would have guessed and would have been happy if we had shown someone had shown us this picture. But if you look at the EEG, it is fully flat. There is no EEG activity all. It is completely isoelectric. If you look at the suppression, it is nearly 100%. So the EEG is almost completely isoelectric and the BIS is 1. There is no electrical activity. We cannot say SEF is wrong. See, SEF is basically saying 95% of the waves are below this frequency. There are no waves to analyze. So it has probably picked up some artifacts and found that those waves are below 17 Hertz and it is showing that SEF is below 17. But because there are no EEG waves at all, this is spurious. So looking at the EEG waveform, looking at other parameters that are on display is and then taking a decision is more important than just looking at one number. This was from a brain dead patient who had come for organ donation. So this activity and this number real. So coming to recent advances, this is now in the market for a couple of years. Bilateral BIS. I showed the sensor before. You can simultaneously put sensors on both sides of the forehead. It gives us the advantage that one side acts as the reference to the other side. So you can make out any changes happening in one hemisphere which are not happening in the other. So it is you can localize the insult also. It shows us the degree of asymmetry also. Now here you can see that the mean frequency on the left side is 0, while mean frequency on the right side is 4. And the SEF on the left side is 3, while the SEF on the right side is 17. That means that the right side of the brain is under adequate anesthesia. So the anesthetic technique is not at fault. There is some insult which has happened, which has caused sudden decrease in EEG activity on the left side. Probably an embolus has gone, which has caused stroke, or probably he has blood on the left side, which has caused a decreased perfusion, something like that. So you can pick up hemispheric pathologies by using bilateral BIS. This is a review of literature. This is all major RCTs which have been done to see if this is useful for eliminating awareness. Now, two of these studies, Be Aware and the one in 2011 by Zhang et al., they say that BIS monitoring reduces awareness. The other three trials, Be Unaware, Bag Recall, and the Michigan Awareness Control Study, they all showed that awareness happens whether you use or BIS or not. So probably we need to understand the monitor a little better, and then probably we will find that BIS monitor is more useful. This is all regarding to awareness, but as I said, awareness is not as big an issue as post-op cognitive dysfunction. Awareness is the incidence is around probably 1 in 2 million or so. Post-op cognitive dysfunction, as I quoted previously, around 25 to 30% in the acute time and around 10% for up to 3 months to 1 year. So, if not for awareness, at least I think this should be used more and more regularly to titrate our anesthetic depth, uh, eliminate POCD, which is much more of a problem in the practice. So, coming back to our case, as I had already said, the bilateral subdural for burial and evacuation, followed by MMO embolization later. So the plan was BIS directed, TCI guided propofol using Snyder model for induction. Because we don't know how much propofol to give, because we don't know how much inhalational to give, so we plan to put BIS in the beginning, then TCI guided propofol, slowly stepping up the targets. Rocuronium for neuromuscular blockade, maintaining anesthesia with a combination of O2R and desflurane, again guided by BIS, Stalblock and titrated doses of fentanyl for analgesia, and Sugammadex for reversal. No long-acting agents, everything guided by BIS and uh, other endpoints. So this is the baseline recording of the patient. We can see that because of his pre-existing dementia, the patient was fully alert, fully conscious, but his BIS was 83. So patients with neurological dysfunction already have a lower BIS value. The EMG is a little high because he's still conscious, his eyes are moving, but the signal quality is pretty reliable. So, and the waveform is also very good. There are quite a few fast waves. So this is probably alpha and beta waves. So this number seems to be reliable. So this will suggest putting the BIS in the beginning will tell us that the drug requirement will be very, very less. We don't have to go from 100 to 50. We just need to go from 83 to 60 in this patient for adequate depth. So next step was induction using Schneider model. When I started at a target of zero point 0.5 itself, his BIS went to 44. So if you have used Schneider model, you would know that in a 78-year-old using Schneider model to achieve zero point 0.5, it will hardly give 2 or 3 ml of propofol. So with that low dose, his BIS fell to 44, and even though we don't want, we achieved a suppression ratio of 7. So he went very deep with just probably around 2.5 ml of propofol is what I recollect. So he already got undesirable effects on the EEG. So that is where we stopped. We kept it at zero point 0.5 and intubated. And as I said, I didn't want to use propofol for the entire case because we wanted quick titration based on this. So I switched over to desflurane, and at a MAC of zero point 0.2, I could achieve adequate levels. The waveform quality is excellent. There is good alpha and occasional delta waves. This SQI is 100. There is no EMG interference. The BIS is what we achieve, what we want in our anesthetic practice. The hemodynamics also look pretty good. So this is what at a MAC of zero point 0.2. Now I'm telling you this is not routine practice. Don't do this for all cases. We don't go so low on every patient. Just to tell you that this can be relied upon even when we are setting extreme targets. So we did the entire case on zero point 0.2 Mac, pretty scared, but just that we trusted the waveform on the value. Exhibit at the end of surgery. Neurologically, he was same as pre-op. He was still confused, disoriented, but fully alert. No recall, definitely no recall immediately, no recall the next day also, and more importantly, no delirium. So the BIS value was reliable. Even though MAC was very less, even though it was scary to do that case, there was no recall and no delirium, which was what we actually targeted when we planned. 2 days later, he was MMA embolization was done. Again, same regimen. propofol induction, desk maintenance, 1.5 hours procedure. Further course in hospital was uneventful. We had explained that patient may need ICU sedation, and if he becomes very violent, we may have to restrain also. But he was very good. On the evening of MMA embolization, he was on his bed reading newspaper, and he said, "If we are happy, he is happy to go home." So that was a very satisfying response. At 3 months follow-up, his memory was back to same status. He was independent doing his activities. His gait had improved, blood control had improved, and no cognitive dysfunction that could be picked up. Oh, thank you. And just to illustrate how we use BIS, this is a short video around 7 to 8 minutes if people are okay. Uh, Permission has been taken, consent has been taken. She was ex-principal of a school. She was happy her face is being shown. She said, "Don't mask my face. I'm okay if my face is shown." She's happy that she's part of a teaching program. So I've not blurred the face so that we can also see her eyes and tongue response as we go. So first part is how we prepare the skin. This is actually not needed as per the company, but we still do it so that the quality of contact is better. Then once it's an alcohol rub or so, uh, once the forehead is prepared, we apply the BIS sensor. You can put it on either side. If you have a bilateral, put it on both sides. By many people put it on the left side because left is supposed to be the dominant hemisphere. Memory and recall probably have higher role on the left side than on the right side, but it doesn't make any difference. Just make sure the contact is good and the waveform is reliable. Once it is applied, you go to the monitor and check the quality of contact. First, you can see the sensor. All four leads are in good contact. Once it is done, look at the signal quality index. Now, as I said, as long as the signal quality index is less than 15, there is no BIS display. Once it crosses 15, we will get a display. And even then, it is still blinking. That means it is not completely reliable because the qualities may not be adequate. Once the SQI crosses 50, you get a stable BIS display. Next is to start induction. We set up the parameters. We are using Elevate Propofol model. So we need to enter the weight, the height, the age, and the gender of the patient. All four demographic parameters for the model to calculate how much to give for what target. Effect site targeting is what we always do. So once ready, this is the baseline recording. The SQI has picked up. So we'll start with a small dose of fentanyl and then start with a target of 1 and go in incremental doses to achieve the target this. Initially start with an effect site target of 1 microgram per ml. So you can see the profile is being delivered. You can see how much is being delivered. So for the target of 1, 4 ml of propofol is delivered, and now it is waiting for equilibration between the plasma and the target site. We reached around zero point 0.8 now. Now even when we are near our target of 1, the patient has still her eyes open. She's blinking, and the BIS is still around 85. So 1 is not definitely not adequate. We'll go up to 1.5. Again, a further bolus is given to bring up the effect site concentration to our target of 1.5. The BIS is slowly dropping. It has come down to 79. If this was a case which was being done under sedation, probably this target would have been enough. But this is a proper surgical case. We want general anesthesia, so we will go up on the target. We'll set it at 2. Further bolus is delivered. We will achieve the target of 2. Total of 9 ml has been given now. So around over 3 minutes. You can see that she's opening eyes on tap. I don't think you saw the tapping, but only on tapping. This has now come down to 65. Okay. And now it is in surgical pains. We make sure that we don't, now she's unresponsive to tap also. So she's adequately anesthetized. Only now at 1.9, this is when we administer our neuromuscular blocking agent because, as I said, they can falsely decrease the BIS if administered early. Even if the patient is conscious, BIS may fall in in the anesthetic range. So, only when we are sure that the target BIS is achieved, we administer the paralyzing agent. We'll wait. Uh, see, this is an alpha. This is probably a delta wave, and there are many alpha waves also. So it still went a little high on the target, so to make sure that will not become light. And once we have achieved around 50 is when we are intubating. I will not show the intubation. The intubation is happening in the background. We can see that the hemodynamics as well as the BIS are pretty stable as intubation is happening. There is no change in BIS. Heart rate has gone up probably from 78 to 82, which is very acceptable. So BIS is still okay. Now there will definitely be no recall of intubation. The tube is in place, fixed. No inhalation being given at a target of 2.3. Now, this is an intra-op image, just on the laparoscope in place. Doing the case on 2, actually, even with this low concentration, the BIS was pretty low. We have gone down further just to show we achieved a BIS of 63 in the intra-op period. Now, this is during closure. We have stopped the infusion. Total 51 ml has gone for the case. And during closure, slowly, as we have stopped the infusion, this is slowly increasing. The patient is becoming lighter. If you can recall, she achieved a BIS of less than 60 at a target of 1.9. So we expect her to wake up around 1. So at 1.4, her BIS is 70. Is becoming light. The heart rate is also going up. BP has also gone up a little. So she's probably starting to wake up. The surgery is done. We'll just wait for the concentration to reach somewhere near 1. It is now 1.1. The BIS is in the 70s. Probably you can call her now. On call, she's opening mouth. I'm opening her eyes. She'll obey commands. She's saying she's okay. Surgery is done. She's showing her tongue. So at a concentration of 1.1, at a BIS of 75 to 80. So we had started with 1. We had reached a BIS of 80. She was arousable but sleeping. That is where we have come back to. So she's arousable but sleeping. Probably a good plane to extubate. So she's opening her mouth, ready to be extubated. Tolerating the tube well because of the low dose of propofol that is still inside her. So no coughing, no gagging, just comfortably sleeping, obeying commands, and ready to be extubated. Just do a gentle suction of the throat, take out any secretions if they are there, and pull out the tube. Once the tube is pulled out, is fully okay, opening her eyes, good tone. The concentration is still around 1. The BIS is around 80. That is where we expect to extubate. The BIS will not reach 100 because there is still some amount of propofol circulating in our body. So this is how we can use BIS to start and end a case. Thank you very much for patiently listening. Thank you.
Thank you, Dr. Vivek. Indeed, that was a real exhaustive presentation that you have given us, and the video was
Thank
really
you, madam.
the cherry on the cake. Uh, if you're okay, can we just take some questions? We have
Yeah,
some,
sure, sure. Yes.
yeah. There are some comments and some questions. Uh, Let me go from the first question. Excellent work.
Excellent, Vivek.
Thank you, sir. Nice to see you, sir. Thank you.
Nice, nice. I was listening since I was going to out, but excellent presentation.
Yeah.
Thank you, sir. Thank you very much.
Vivek, there's a question from Dr. Sugam. Uh,
Ah,
he's saying whereas RBR, that is relative beta ratio, is a logarithmic function, BIS reading is a linear measure. Thus, reducing BIS is of logarithmic significance, and at what individual reading range?
so actually BIS is a logarithmically derived number. So behind this, there is multiple calculations which go on. They look at all the four indices which I said. In the deeper planes, the BSR and QSI take predominance. In the lighter and the sedation range, the RBR takes predominance. But for each level, they do all the four analysis. And then, like I showed the different independent group showing at what levels, what BIS we get. That is how we can, but this is not just a linear number. Behind getting to that number, there are multiple logarithmic calculations which happen. Just that because they haven't put it out in the public, we don't know how it is calculated, but it is still a statistical calculation. So all the four variables are important, just that one variable takes predominance because of the waveform characteristics at different planes. So at sedation levels, RBR is important because most of the waves are in beta range. At general anesthesia hypnosis levels, the SFS becomes predominant because there are some fast and some slow waves. And at very deep levels, the BSR and QSI become important because most of the EEG is suppressed. But at all points, before they come to the number, all four parameters are taken and calculated. There is always calculation behind the number.
Dr. Pooja would like to know that if muscle relaxants can falsely reduce BIS, and we do use muscle relaxants during general anesthesia, is there any way it
Yes.
can be differentiated?
We can't differentiate as such, but like I said, like how I showed, if you want to use BIS to titrate your anesthesia, make sure you have achieved your target anesthetic before you give muscle relaxant. That is what I said. You don't paralyze the patient unless you are sure that the hypnotic agent has brought down the BIS to our target levels. It will not bring down to very low values. Probably BIS will come down from 100 to around 70 to 75 with muscle relaxants because only some EEGs in the 30 to 70 hertz range where there is an overlap between EEG and EMG. Those get eliminated, and there is small drop in BIS. We will not reach our surgical depths, but probably we may reach our sedation depths. So one way of making sure is probably to make sure that you have reached the target BIS by using your hypnotic agents alone. And once you're sure that that has reached your, by giving your propofol or other agents, if you have attained your target BIS, only then you paralyze your patient so that there is no doubt as to what has caused the fall in BIS.
There are a couple of questions, but if I can summarize, they all would like to know if there is any comparison with entropy. So between entropy and BIS, is there some way you can throw some light on?
Entropy also has a similar, I mean, we don't know the algorithm behind entropy also. That is by GE. They have calibrated it such that it gives us the same values as BIS. The main drawback with entropy was they introduced it at around the same time when BIS 1 or probably BIS 2 were in market. And then BIS, they went back, they collected data from the market, and then they refined their logarithm, I mean algorithm, and they came up with better versions to eliminate artifacts and to uh, give us more reliable information. Entropy didn't do that. Entropy still has the original algorithm which came in the market in the beginning. It is there. It isn't revised. So anything which is revised, anything which is collecting feedback from the market is probably a better, more reliable tool. The only advantage which entropy initially said was that they gave us two values, state entropy and response entropy. Now, what they did different from BIS was that they didn't eliminate EMG. They took EMG as an indicator of pain. They said frontalis doesn't get paralyzed under anesthesia. The eyeballs still move if there is pain. So they said EMG under anesthesia is an indicator of pain. They said if the response entropy is increasing, it is because of EMG. So you will probably need to supplement your analgesic. That was a very sound theory, but it didn't work in clinical practice. So it is not very reliable. It is still a good monitor, not that it is not, but just because BIS has been refining their work, BIS has become more popular, and it has become more now that it is generic, and for entropy, basically you need a GE monitor. BIS you can incorporate with other monitors also. So that is one advantage of BIS.
Can hypocarbia by reducing cerebral blood flow along with benzodiazepines or hypothermia
Yes,
that
yes,
reduce the cerebral oxygen consumption suggest falsely reduce BIS reading?
yes, it can happen, but at clinical hypocarbia, what we achieve are around 25 to 30. Doesn't happen much, but in a borderline brain where the brain is already injured, we have seen that in a head injury patient who is hyperventilating, you paralyze and then you hyperventilate. I mean, you give a hypercarbia. There is already an ischemic consult. I mean, not even this. If you're monitoring EEG, you can see that with extreme levels of hyperventilation, hypocarbia, I mean, there is cerebral vasoconstriction. So EEG also slows down. That is why one of the guidelines in BTF guidelines, where Brain Trauma Foundation, they have said avoid hyperventilation in head injury because there is already reduced cerebral perfusion. So EEG and BIS definitely fall with hyperventilation in head injured patients. In normal patients, I think autoregulation kicks in. Doesn't We will not see that much, but in a borderline brain which is already injured, uh, that is also hyperventilation can definitely cause fall in BIS. And it is not false; it is actually true. The fall in BIS is probably because of worsening ischemia.
Dr. Ajay has asked whether if your patient has taken some CNS stimulating or alterating drugs, will that bring about any change in the BIS?
Yeah, not very sure. I mean, I'm not very sure how the stimulants work on the EEG. So I'm afraid I'll not be able to answer. If anyone else has any experience, but uh, I don't, I honestly don't know how it will work. So probably
Dr.
I'll need to
Shugam,
go back and see what
Dr.
will
Sh
be.
I think Dr. Shugam was the one who was asking. Do you have any experience, sir?
Yeah, actually, all the cryptic question that I put was just to improve the quality of discussion of this
Wonderful.
meeting. So now we
Trust
are
me
actually
to do
at
that.
ASL level.
Trust me to do that.
Yeah. So considering the effect of the cerebral stimulants, I mean, as you did mention, Dr. Vivek, about ketamine and nitrous oxide,
Yeah,
these are they have the same effect that they make falsely elevate
elevated
the
BIS.
the BIS reading number by whereas they are actually increasing the depth of anesthesia. So we are
Yes,
doing a good job in spite of what the BIS would have us believe.
yes, correct,
Right.
correct.
Something similar may happen when we do cervical spine or lumbar spine cases. For example, many times we use somatosensory evoked potential
Mm,
monitoring, and one set of electrodes actually sits on the scalp
mm,
and the other one distal to the site of surgery, as we all know. Now, the job of the scalp electrodes is to secrete electricity in the scalp. Although it is supposed to take the path of the least, the shortest path
resistance.
to
Okay,
complete the circuit, shortest or whatever path, the electrical field is by Fleming's left hand rule. So
okay,
if our BIS electrodes are so sensitive
correct,
to detect voltages from somewhere inside the cerebrum across the skull, why would this set of electrodes not give an interference? And
correct.
after asking this around the world, I still not got the answer as to what noise cancellation is incorporated in the monitor to address this. There actually is not. So you can
No,
have
no,
artifacts
but
like that here
actually, if
to
we have seen, they have used BIS electrodes in cath labs when aneurysms are coiled. So there is one kind of coil which needs an electrical discharge for the coil to be released into the aneurysm. So that electricity also interferes with the BIS. There is suddenly a high BIS reading. It is a short duration, and once that electrical activity stops, the BIS comes back to the base level. So that electricity also interferes. Probably the MEP
no, no,
elect
somatosensory
correct.
has got this dual problem. It is electrical
Yeah.
interference by itself, and it also stimulates, like all other muscles. that are used in that monitor, it also is sitting over the occipitofrontalis. So it is bound to cause
Generate
stimulation
some,
and
yes, yes, yes.
action potential activity in the occipitofrontalis, which is right under your BIS sensor.
Correct, correct.
This does happen, but the American company just believes that people will not be cerebral enough to ask these questions, but we should.
Yeah, correct.
Thank you, sir.
Agree. Agree.
There's a question from one of the students, which I'm sure you have answered this in your course of your talk, but I think just for his satisfaction, may I take that question with your
Yeah, yeah.
permission? Is there any
Sure.
relation between BP and pulse with BIS, sir? As some patients show tachy and high BP even when BIS is around 40 to 50.
Yes, so BIS is completely only looking at the cerebral cortex. Now, even if the BIS is between 40 to 60, as I said, patient can still have pain. Hypnosis and analgesia are two different components, especially if you're using TIVA. An agent like propofol doesn't have any analgesic action. Any spinal inhalations probably can suppress the spine also a little and cause some analgesia, but propofol has no analgesic action. So even when there is adequate dose of propofol going, the BIS is probably in the surgical range 40 to 50. That doesn't mean patient will not experience pain. So hypertension, tachycardia, in spite of adequate hypnotic depth, is very, very common. So all you need to do is supplement a little more analgesic. If there is a regional catheter in place, give an additional bolus or give a bolus of opioid. Or if that is not satisfactory, probably add one more agent like dexmedetomidine. So that is how actually your practice also becomes more evidence-based. So instead of when there is BIS of around 40 to 50 and there is hypertension, you don't have to give a hypnotic dose. You don't have to increase CO or give a dose of propofol. All you need to do is supplement analgesia. So that is how so probably you will avoid going into deeper planes of anesthesia and also achieve adequate analgesia. So there is no relation between pulse rate and BIS. BIS is completely a neural monitor, while pulse rate and BP are cardiovascular monitors.
Dr. Amit Shah would like to know that how does SAF seen with IONM works in comparison with BIS, and when we may have interference with SSEP, and which monitoring you all will advocate with IONM with SAF value versus BIS.
Sir, actually in our practice we put BIS from the beginning, and then once the IONM is set up, we look at the EEG as well as the BIS. Now BIS will, especially if it is a cranial surgery, the BIS sensor will peel off after some time. It will at least get soaked, so it will become unreliable. But it will at least till that point it will help us guide our anesthesia, because as you know we cannot put scalp electrodes and titrate our anesthesia from the beginning using an IONM monitor. But once that is in place, we will take a few EEG waveforms. We look at the raw EEG. We look at the SEF also. Once we get the SEF in the IONM and then we have an SEF in the BIS, we can see how well they correlate, and then we can decide whether which of them is more reliable. And then we also use the spectral array, the DSA, colored DSA in the IONM. So we target an alpha on delta pattern in that monitor. And then if this is still working, then fair enough. We have two monitors, which will become more robust than having a single monitor. But more or less, the BIS will go off in some time. So by then, the IONM would have taken over, and then we can titrate based on SEF and the waveform. And like I said, looking at the waveform and looking at other parameters is also as important as looking at the BIS number. The more we look at waveform, the more we learn to identify the waveforms. I think the more and more useful EEG will be in the future.
So density spectral array would be like, once you have that color density spectral array would be, I
Sir,
think, a better way
definitely,
of
sir,
looking at
definitely.
it,
Because
correct? Yeah.
that, yes, it is looking at all the waveforms. BIS is looking at what it wants. DSA is looking at everything that is being given to it. And then there is simultaneously the EEG waveform also. So it is probably a more reliable monitor than just BIS number.
Dr.
Thank you.
Kulkarni has says atrophic brain in elderly and BIS value. What is the reliability?
Uh, BIS is age independent. As long as the cortical neurons are firing well, the BIS number is reliable. But like I showed in our patient, he had Alzheimer's, so probably he had a cortical issue, dementia or had already set in. So his baseline BIS itself was low. So how far we can trust that is still a question. But as long as the cortical function is fine, as long as the patient is alert, I feel the BIS is reliable. But BIS is definitely age independent. After 6 months of age, BIS can be pretty well used at all ages.
Dr. Vivek, your patient underwent a second time a meningeal artery, this thing, embolization.
Embolization, yes, ma'am, yes, ma'am.
Does that require to give an anesthetic?
Yeah,
Or
yeah, it is
because the patient
by practice.
was Alzheimer's and you would have unpurposeful movements? Was that the reason that you had given?
No, no, by practice, all our neuro interventions are under general anesthesia. Our radiologist, even for strokes, previously he used to do all his stroke interventions under local with a standing by. But now there is enough evidence, and he feels that with under general anesthesia, he doesn't have to worry about hurrying up or worry about patient moving. The image quality is better. So he just asked for general anesthesia and all neuro interventions. So there is no conscious sedation anymore in cath lab for neuro interventions. Even a fully conscious, fully cooperative patient, we would still do it under general anesthesia.
The last question, I think, of the day, which I can see is Dr. Shinde has asked is, does it show variation in the brainstem activity analysis?
Brainstem activity, I would assume whether brainstem, that means whether brainstem dysfunction will reflect BIS changes. The thing is, there is constant uh, feedback between the brainstem and the cerebral cortex. So any brainstem dysfunction will cause a loss in the positive feedback to the cerebral cortex. So there is some drop in EEG, even in brainstem dysfunction, in the drop in EEG from the cerebral cortex also. So the BIS would fall a little, but the thing is, the reticular activating system, which is responsible for consciousness, is in the brainstem. So any brainstem dysfunction, the patient will be deeply unconscious. GCS would be around M2 or maximum M3. For that GCS, we would expect the BIS to be around 20 to 25. We will not see that because the cortex is well, the cortex is working well, but the only thing is it is not getting any stimulatory feedback from the brainstem. So it is not working to its full capacity. It is slightly lower than that. So we would expect the BIS to be around somewhere around 70s in a brainstem dysfunction, but the patient will be deeply unconscious, giving any minimal response to stimulus. So that is the fallacy between in the BIS. It because it looks only at the cortical function, any subcortical stimulus like a small stroke in the basal ganglia is hardly picked up. That is one of the reasons why BIS is not such a great monitor to pick up strokes in vascular interventions, because BIS looks at only one part, only the temporal lobe on the side which is put. Now the deeper structures like the basal ganglia or the internal capsule, where any small amount of stroke will be catastrophic, patient will be hemiplegic. That is not going to be picked up by a superficial electrode like this. So there we need other monitors. But for consciousness, uh, this is a very good monitor.
Dr. Shiv Kumar has just had a case of cerebral fat embolism 1 month back.
Hmm.
And the patient had a baseline BIS of around 70 and with just 1 mic propofol going for burst suppression. How would you advise him to go ahead with in such kind of patients?
So it is probably something similar to what I just showed. We see similar things in vascular when aneurysm patients come for surgery as well. They seem to be okay. They will be GCS 13, 14, but with around 0.5 to 1 mac of propofol, just burst suppression sets in, which drops to 30 and 40, and then they take a long time to come back to surgical levels. So in that case, as long as the signal quality is good, as long as the waveform is good, we tend to trust the BIS and then titrate. I mean, doing a case on 0.5 is very, very taxing. You will be very scared to go so low on anesthetic, but with practice and with trust on the monitor, we will start doing that. We still don't understand how subcortical injuries affect the cortex. We just know that consciousness comes down. So we still don't understand. It is very complicated as to how those insults affect BIS monitoring. But I think at that level also, at a concentration of around, like I showed in the case that I just discussed, we achieved burst suppression with point at a target of 0.5, and then we did the entire case at 0.2 Mach, which is very dangerous. We will not be able to justify why we did that in case something goes wrong. But as I said, the waveform was good. There was no reason not to trust BIS in that case. So we went ahead, did that, and then we had good outcomes. So as long as we know the limitations, as long as we are still looking at the waveforms, then I think BIS can be trusted. But there are still quite a few limitations. It is not a foolproof monitor.
Dr. Vivek, have you gone back and put in a questionnaire to your patients about awareness? And if yes, what is the protocol
Yes,
that
the
you use?
awareness I ask everybody. It's not a formal BRICE questionnaire, but generally I just ask how they did under surgery, what they recall. So it is like they recall a painful injection being given, or they recall a mask being held. We have hardly had any issues regarding to awareness. A couple of patients have said they were dreaming. I'm not very sure whether dreaming can be considered awareness, but none of them have recalled surgical stimuli or there has been no explicit recall. Uh, but yes, dreaming, I don't know. I still am yet to find whether dreaming is acceptable or not, but no explicit recall.
I think, Dr. Vivek, you have kind of satiated us with all your answers and the questions, I'm sure, as so the participants.
Thank you.
Dr. Subramanian, would you like to say a few words?
Yeah. First of all, thank you, Vivek. It was an excellent exposition of this topic.
Thank you, sir.
Generally, what I can see, the trend is, you have in your talk, you have gone through wherein which it is not just about the index number, what we have to look at. There are more things from the BIS what we can gain, not just the index number. You clearly elucidated it is possible for all of us to look at the waveforms and take a guess what could be happening, what kind of waves we are seeing. And also you have illustrated that when we put the BIS monitor, it's not just the BIS number. We have to look at first is signal quality. And you also showed us, where to look at suppression ratio, what it means. You also helped us understand the BIS number will not come unless SQA is so much and the EMG is so much. All this will add to how we use this clinically. This is a decision support system as I see. Just like other monitors are there for decision support, whether BP or anything, this is excellent decision support for us to ensure that we give exactly the optimal anesthesia with all the knowledge what we have. There may be variations, as we all know, there will be variations. There will be some people who will be sensitive with 0.5 itself, they can achieve burst suppression. Or some people will not achieve even at 6 microgram per ml.
Correct.
So
Correct.
you have elucidated all those parts excellently. I think I should thank Kalpana to have brought in this topic in this domain. And what I also want to say is, as part of the AOTTA, we are committed to bringing in the newer topics, what is happening around, and especially what is relevant to the target controlled infusion and TIVA. We will continue to bring it, and we have introduced a new way of collecting the information, making you all participate in it by introducing the questionnaire and survey. We will try and circulate this questionnaire after the class so that we also get a feedback that how much difference has it made for you in your understanding. So I just want to thank every one of you, Vivek, Kalpana, and our entire executive committee of the AOTTA and all those who have participated. I'm really thankful for a Sunday evening. I'm seeing so many people join in. I can't ask for more. Thank you all.
Thank you, sir. Thank you very much. Thank you, Dr. Kalpana, also for giving me this opportunity. Thank you.